Good evening, everybody, and welcome to this wonderful evening. Jaswinder Kaur, Prajakta Bhagat, Rocket Trader, Manas Agarwal, Sauni Mandal, Ritu Raj, and everybody across the country. Today we will have a short session of about an hour because to maintain continuity is all that is important. So, uh, we were discussing endocrinology. So, in the endocrinology, one of the favorite topic of the examiner, there are about totally 22 topics in endocrinology, which we are going to revise. So, let's make the great beginning. What is the drug of choice prenatally if you are suspecting congenital adrenal hyperplasia with 21 alpha hydroxylase deficiency if you made a diagnosis? In congenital adrenal hyperplasia, why the adrenal become hyperplastic is my question to all of you. Please punch whether the voice is loud and clear. Why the adrenal enlarges? If when the adrenal doesn't produce a steroid, normally low steroid is a stimulation for the pituitary to release ACTH. So the low steroid levels will make ACTH become abundantly produced and that lead to development of the hyperplasia of the adrenal. So how do we break this cycle is a very important thing. So that is if you supplement the steroid. So which kind of steroid do you want to choose is the examiner's question. Dexamethasone is the most powerful composition of the steroid by virtue of the strength of the steroid is the one which is basically delivered. Now, you all know that congenital adrenal hyperplasia has 4 different enzyme deficiencies: 21, 17, 11 and 3 alpha hydroxylase deficiency. And fundamentally in all this, what is decreased? Corticosteroid is basically decreased. But in some of the congenital adrenal hyperplasias, mineralocorticoid is increased, and in some of them there is an increase of adrenal androgens, and in some of them there is a decrease of the adrenal androgens, and in some of them there is a decrease of mineralocorticoids. So mineralocorticoids may increase or decrease, adrenal androgens can be increased or decreased, but in all of them corticosteroids are fundamentally decreased in all congenital adrenal hyperplasia. Sound not clear? Can you please little? Can you check whether the okay? Is it better? Yeah? Is it clear? Okay. Now this is one of the. Do you want to check the sound? Yeah. Okay. Now, in the exam hall, suddenly examiner will ask you, 21 alpha hydroxylase में mineralocorticoid बढ़ेगा, mineralocorticoid deficient होगा, और adrenal androgen बढ़ेगा, और adrenal androgen कम होगा. At that time, you can't draw the table and then make up or down and all those things, right? Unless you have a visual hallucination with a multi-personality disorder, it is very difficult to recall it in the exam hall. So there is one simple mnemonic which you can remember. There are two things. One is mineralocorticoid, other is androgen we are talking about. So use the mnemonic A, T. A is aldosterone, T is testosterone. If you look at 21 alpha hydroxylase, 21 has two numbers, 2 and 1. So 1 jahan rehta hai, take it as increased. So what is increased in 21 alpha hydroxylase, doctor? Testosterone is increased. That is the reason there is a virilization. Then what is decreased? Aldosterone is decreased. And that is the reason it is called salt losing type of adrenal hyperplasia. Then 17 alpha hydroxylase. 17 में 1 क्या होता है? Increased. So aldosterone is increased. So hypertension रहता है 17 alpha hydroxylase में. And testosterone is decreased. Then 11 beta hydroxylase में क्या होता है? 11, 1, 1. That is the reason aldosterone is increased, testosterone is also increased, and that becomes, yes. Is there any issue? So it is clear here. No, but we are seeing it is clear, right? Right. Video is fine. Ritu and everybody, you should look, how is your internet? Right? If the internet speed is slow, YouTube guys are intelligent guys because they did not go to medical college. Right? They did not take a NEETPG exam. Automatically, they will try to make it more clearer if your internet is good. Okay. All right. Thank you that most of you are able to see it fine. So Akash is saying, sir, this is one of the best trick I have learned so far. Good. Thank you. I mean, does Akash want to say, of all the crap he had been listening in this evening lectures from October 15, this is the only thing is good, or about adrenal hyperplasia that he tried everything, this trick is good? Be very clear, Akash. अगर आप प्रशंसा दे रहे, विमर्शा दे रहे, समझ में नहीं आ रहे, so you think this is the only thing best in all these days, or in adrenal hyperplasia this is the best? Yeah. So once more, Monica came a little late, so for the sake of Monica Sharma, let us once more revise. Adrenal hyperplasia, congenital adrenal hyperplasia, exam hall में किस एड्रिनल हाइपरप्लेसिया में एल्डोस्टेरोन बढ़ेगा, टेस्टोस्टेरोन बढ़ेगा या कम होगा, टेंशन रहेगा. सो टेंशन नको, राइट? सो 21 alpha hydroxylase, 1 is increased, that is testosterone is increased and aldosterone is decreased. Hence it is salt losing. 17 alpha hydroxylase, 1 means, the numeric 1 is, means increased. So aldosterone is increased and 11 beta में 1 है. So इसलिए both aldosterone, testosterone are increased in 11 beta hydroxylase is what you have to remember. So if you take the 21 alpha hydroxylase deficiency, cholesterol become pregnenolone. Pregnenolone become progesterone, that become aldosterone. Similarly, 17 hydroxyprogesterone become cortisol. इन दोनों के लिए 21 alpha hydroxylase का जरूरत पड़ेगा. इसलिए aldosterone is decreased, cortisol is decreased, but everything goes and makes the androstenedione, androgen levels to increase. So that is 1 is testosterone है ना, so this is increased. 2 is not 1, so it is decreased. Aldosterone is decreased. And 17 hydroxyprogesterone levels are increased in case of 21 alpha hydroxylase is what need to be remembered. So to the mother, if you happen to give dexamethasone at 20 micrograms per kg per day, then that is the way by which you can treat antenatally the congenital adrenal hyperplasia. What is glucose fever and what is it related to? Typically, glucose fever is seen in Addison's patients who have adrenocortical deficiency. If you happen to, for example, if a Addison's patient, typically how does he present? Adrenocortical insufficiency he'll come with severe hypoglycemia. So if you check the sugar, it will be only 30 or 40. Immediately, if you happen to jump without knowing that he is a adrenocortical insufficiency patient or a adrenal suppressed patient, if you only give steroid, if you only give glucose without giving steroid, then they will develop a high fever followed by collapse and sometimes even death also. I can never forget in my life, one of our patient, Murali was the name of that patient. I still remember almost 15 years back when I was in MD, first year junior residency. So she is a mathematics topper in class 10. She was actually identified very early SLE. She was in a lot of steroid dose, exogenous steroid. Because of that exogenous steroid that she was receiving for immunosuppression, her adrenal got suppressed. And because of the exams, 10th class exams, for almost 2 days she was working very strenuously. Obviously, when you are stressed out, your steroid levels shoot. But if your adrenal is suppressed because of exogenous steroid, your steroid levels cannot compensate. So she came in a severe hypoglycemia, and when she came in severe hypoglycemia, first thing that we do is we start a glucose infusion. Suddenly, high grade fever. First time I learned what is glucose fever with that patient, and I can never forget that experience. Of course, immediately we have given hydrocortisone injection, etc. So, but reading is different and treating is different. That's what I'm trying to tell you. Tomorrow you may become a dermatologist. Lot of crap you are reading in general medicine, but you may not practice general medicine. So don't try to become a expert by reading Harris and big books. They will only bring you confusion. Few points, focused way, only for exam sake you review, and more extensively you can always review when you join your post graduation. When there is a hypoglycemia in with congenital adrenal hyperplasia, how do you want to best manage is a very important question. Hydrocortisone is always like a immediate in action. All other steroids will take some time before they start acting is what you need to remember. So we give typically 10 to 20 milligram per meter square for 24 hours, 100 milligrams of hydrocortisone, F-corlin injection. F-corlin is a very common brand for hydrocortisone, just like Visolon is for the prednisolone, right? So hydrocortisone injection is the one. Now comes the favorite question of the examiner. You will remember me in the tomorrow's exam hall. Saumi Mandal is asking, sir, please tell how do we differentiate 21 and 3 beta? Yes. NEETPG examiner's favorite area, congenital adrenal hyperplasia, testicular feminization syndrome. If you are Dr. Murali Bharadwaj students, you should only answer these questions, nobody else in this world. So if you look at the steroid conversion, doctor, if you take cortisone, 25 milligrams of cortisone is equal to 20 milligrams of hydrocortisone is equal to 4 milligrams of methylprednisolone equal to 5 milligrams of prednisone, and prednisolone is equal to most powerful is 0.75 milligrams of dexamethasone is what you need to remember. So hydrocortisone is short acting. So if you look at the relative mineralocorticoid ability of the hydrocortisone, it can be called 1.0. Whereas dexamethasone has 0 mineralocorticoid efficiency. It is a pure glucocorticoid. Prednisolone has 0.8 mineralocorticoid efficiency is what you have to appreciate. So this is one thing, doctor. यू मेडिको ऐप में आप इस स्लाइड को बुकमार्क करके बिठाना है. Have you uploaded in the YouMedico app the Sunday yesterday's notes and video? Very good, very good. So you can go. Yesterday, some of you have missed the Sunday mock test discussion. So Sunday mock test notes and the video, both of them got uploaded into the YouMedico. There are some excellent points we discussed yesterday, and there are a lot of things that are worth bookmarking in the yesterday's class. Now, congenital 17-hydroxylase deficiency, why it leads to development of hypertension is my question to all of you. There is a substance called deoxycorticosterone. This precursor by itself has got a mineralocorticoid activity. That is the reason that leads to development of hypertension. Now let us look into 17-hydroxylase deficiency. Cholesterol become pregnenolone. Pregnenolone progesterone बनने के लिए 3-beta-hydroxysteroid dehydrogenase is required. And that progesterone become the DOC, that is the deoxycorticosterone, and that deoxycorticosterone in turn will lead to the formation of corticosterone and aldosterone is what you need to remember. So if you look at progesterone to deoxycorticosterone, you require 21 hydroxylase, but deoxycorticosterone to aldosterone के लिए you require 11 beta hydroxylase. So if the 11 beta hydroxylase is not there, then the deoxycorticosterone does not convert into aldosterone or corticosterone is what you need to basically appreciate. So where does 17-hydroxylase comes into picture? Pregnenolone become 17-hydroxypregnenolone. For that you require 17-hydroxylase. अगर 17-hydroxylase नहीं है तो all this pregnenolone become progesterone, progesterone become deoxycorticosterone, and deoxycorticosterone levels will increase. And that increased deoxycorticosterone is the one which leads to the development of hypertension in case of the 17-hydroxylase deficiency is what you have to basically remember. So this is one table, doctor. You have to be 100% sure and bookmark in your YouMedico app. Once more, let me show you a vertical descent of the story. That was a horizontal spread. Pregnenolone become progesterone. Progesterone by action of 21 hydroxylase become deoxycorticosterone. Deoxycorticosterone become corticosterone, and for that you require 11 beta hydroxylase is what you have to remember. So in 11 beta hydroxylase deficiency, deoxycorticosterone levels become accumulated is what you need to fundamentally remember. Now, congenital adrenal hyperplasia because of 11-hydroxylase deficiency, how do they present? They present with hypertension. Why hypertension? Just before we discussed, 11 beta hydroxylase is required for converting deoxycorticosterone to corticosterone. अगर वो नहीं है तो deoxycorticosterone get accumulated. Deoxycorticosterone has got a aldosterone-like effect, and that lead to development of hypertension in case of the 11 beta hydroxylase. Then if 11 beta hydroxylase, if it is not there, what will happen? All this progesterone, 17 hydroxyprogesterone, all this will be diverted towards formation of excessive testosterone. So that is the reason what will happen? There is a development of virilization is what you have to fundamentally remember. So that is the reason congenital adrenal hyperplasia type 11 beta hydroxylase may one is increased. What is increased? The mineralocorticoid activity caused by deoxycorticosterone is increased. That is the reason there is a hypertension. Also, there is a increase in testosterone activity. So that is the reason there is a virilization. And high mineralocorticoid activity, what will it lead to? Retention of sodium and loss of potassium into urine. And that is the reason there is a development of hypoglycemia. And already we discussed, high aldosterone के वजह से acidosis आता है या alkalosis आएगा? Aldosterone will lead to sodium retention and potassium and H plus ion loss into urine. That is the reason H plus ion loss should lead to metabolic alkalosis is what we have to fundamentally remember. So that is the reason what is accept about it? It is the metabolic alkalosis but not acidosis in case of the 11 beta hydroxylase deficiency. I don't know how many of you have followed what I am talking. Did anybody have not followed? Please punch so that I will once more explain. Even if one of you say that, no sir, समझ में नहीं आया बोले तो, I will repeat. अगर आप please punch. Did anybody followed? Roger says followed. Alek Sheth says no followed or followed. Anyone want a repeat of this story? Please repeat sir. चलो प्रवीण गौड़ बोल दिया. गौड़ बोल दिए तो हम करना ही पड़ेगा, right? So yes, I once more repeat to you. Shanti says no. 11 beta hydroxylase नहीं हो तो क्या हो रहा है? All the precursors stop. No cortisol, no aldosterone. Agreed? Here there is a small confusing point. That's the reason I am trying to tell you so many times. Since there is no cortisol, no aldosterone production, all the precursors are diverted to form testosterone. Agreed? That is the reason there is a excess androgen and virilization. But because of the 11 beta hydroxylase deficiency, deoxycorticosterone become excessively accumulated. This deoxycorticosterone itself has got a mineralocorticoid activity, and that acts like a mineralocorticoid, and that lead to the development of the sodium retention, potassium loss, H plus loss into urine, and that lead to hypokalemia, metabolic alkalosis, virilization because of excess testosterone, and hypertension because of excess deoxycorticosterone. So the aldosterone is low, deoxycorticosterone is very high, is what you have to basically remember. So hope you all understood. Once more, बार बार बोलो, हजार बार बोलो, बोलने की चीज है, ओ दिलरुबा, दिलरुबा. So that's what you need to remember. Don't forget मेरे दिलरुबा, this important table. ठीक है? ये T, aldosterone, testosterone डाल दो. 21 hydroxylase में aldosterone decreases, testosterone increases. 1 जो होता है increase होता है. 17 alpha में 1 जो होता है increased. What is 1 in AT? A. So aldosterone is increased, but testosterone is decreased. Then 11 beta में both are 1. So both aldosterone, both testosterone, दोनों are basically increased, is what you have to basically remember. I hope our respected NEETPG Chief Minister Gaud will agree that he understood, right, doctor? This is the table. You all need to make a very important bookmark in the UMedico app and set up a reminder. Okay, doc? If you look at 21 hydroxylase, it is the chromosome 6. 11 beta, chromosome 8. 17, chromosome 10. And 3 beta hydroxysteroid dehydrogenase, chromosome 1 is what you have to fundamentally remember. And adrenal crisis is a big problem in 21 hydroxylase and 3 beta hydroxylase, and androgens are increased in 21 and 11 but decreased in 17 क्योंकि T is testosterone, second letter. 17 means 7 is the second letter. 7 means decreased. If it is not 1, it is decreased. So you can remember androgen is decreased. That's what you have to fundamentally remember. Now, doc, Carney's triad. What do you see in Carney's triad? Welcome to Alok Shah. I am seeing for the first time. Vipul Chowdhury also. Very good, very good. Now, you should remember Carney's triad mein, what are all the cars that are there? Gist, gastrointestinal stromal tumor, pulmonary chondroma, extra-adrenal paraganglioma. These are the triad of features which you see in case of the Carney's. The patients of Carney's need to be remembered because they have increased risk of developing pheochromocytoma, esophageal leiomyoma, and adrenocortical adenoma is what I want to underscore. Then you have a Carney's complex syndrome. A syndrome जो है वो autosomal dominant है. इसमें myxoma, spotty skin pigmentation, endocrine overactivity, and the breast ductal adenoma and myxoid fibroadenoma are the classical features. Then you have a syndrome of it. उसमें gist and paraganglioma, which is familial, are the components. That is the story of Carney's. Purely बट्टी मारने वाला fact है. No intelligence required. अभी बोले यार आपके समझ में कितना समझ में आ गया अभी देख लेंगे. Female child, hypertension, virilization, hyperpigmentation, and what is she most likely to be suffering from? Hypertension, virilization. Very important clue. Hypertension means mineralocorticoid is high. Virilization means androgen is also high. So what is it most likely to be? Very good. Riti Kumar, Sushmita, Rituraj, Sai Monica, Gaud साहब बताइए आप क्या बोल रहे हैं? What is your answer, Mr. Gaud? Neeta Mahesh. Excellent, excellent, excellent. खुश हो गया हम. आज रेडी है आप? एंड्रोजन बढ़ गया या टेस्टोस्टेरोन? ये एल्डोस्टेरोन बढ़ गया या टेस्टोस्टेरोन बढ़ गया? दोनों बढ़ गए तो 11, 1, 21 में aldosterone is low, testosterone is high, and 17 में aldosterone is high but testosterone is low. That is what you have to remember. In the tomorrow's exam you will definitely remember it. So 21 alpha hydroxylase में aldosterone is low, cortisol is low, but androgens are elevated. That is what you need to ultimately remember. So this is your benchmark, doctor. 21 में testosterone is elevated, aldosterone is low. 17 में aldosterone is high but testosterone is low. 11 में both aldosterone and testosterone are high. That is what you have to conclude. Once more, NEETPG 2013-14 में हर एक बार एक congenital adrenal hyperplasia क्वेश्चन के बिना पेपर नहीं रहेगा. So 17 alpha hydroxylase deficiency, what does it lead to? You know very well, increased production. 1 क्या होता है? Aldosterone. 7 क्या होता है? Testosterone. So testosterone is decreased and aldosterone is increased. That is what you need to remember. अभी आ गया very important question. 3-beta hydroxy steroid dehydrogenase, what does it lead to? Production of what? It leads to production of excessive dihydroxy epiandrosterone. Why? If you know the table, you know that why. Answer for the why. So let us look into why this colavaridi. Let us look into it. So doctor, pregnenolone to become progesterone, you require 3-beta. 17-hydroxy pregnenolone to journey towards cortisol, you require 3-beta. इसलिए cortisol कम हो जाएगा और aldosterone भी कम हो जाएगा अगर 3-beta HSD deficient है तो. Then क्या हो जाता? All these precursors will convert into dihydroepiandrosterone. But the dihydroepiandrosterone to journey towards testosterone, typically you require 3-beta. इसलिए testosterone कम, cortisol कम, aldosterone कम, सब कुछ कम, and that is 3-beta. 3 things are come. What is low? Cortisol low, aldosterone low, testosterone low, everything low. That is 3-beta. That is what you have to basically remember. And does this fit into our AT mnemonic? AT mnemonic. Will this fit? Can you give me the board? Yeah. Yes. हमारा AT स्टोरी क्या है बोलो? Congenital adrenal hyperplasia में aldosterone, testosterone. 21 में क्या होता? 17 में क्या होगा? 11 में क्या होगा? 3 में क्या होगा? 3 होता है 0-3. Whenever 1 is there, that means increase. So 1 is the second number. So testosterone increase. 1 is the first number in 17. Aldosterone increased. 1 is both the numbers. So both aldosterone, testosterone increased in 11. And 0 and 3, neither of them are 1. So both of them are decreased in case of 0-3. And 17 में 7 is not 1. That's the reason testosterone is low. 21 में 2 is not 1. That is the reason aldosterone is low. That is what you have to ultimately remember. But what is common to all these things? If you look at the corticosteroid, it is low, 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 low. That is the reason it all this will stimulate ACTH production and that lead to the adrenal hyperplasia is what you have to ultimately remember. अभी पता चल गया आपको. Now doctor, but don't tell your friends, Dr. Murali teaches like this. Of course, Ravi is giving lot of kisses. Almost my cheeks are all aching. So, McCune-Albright syndrome is characterized by what? It is characterized by cephaloid spots. So, precocious puberty, cystic changes in the bone, cephaloid patches, and low FSH and LH levels. This is the classical combination which is called McCune-Albright syndrome. So, this is more commonly seen in the case of the girls. She is a girl, which you are seeing. And you can see the presence of a huge cephaloid spot is what you need to basically remember. Male pseudohermaphrodite क्या होता है? So, male XY genotype, but pseudohermaphrodite because there are female external genitalia. So why does it happen is a very important question. So you should remember, Leydig cells are there, right, doctor? Leydig cell hormone receptor abnormality is the main problem. Leydig cell produces testosterone, right? अगर वो Leydig cell काम करना बंद कर दिया, so testosterone का तैयारी नहीं होगा. अगर नहीं हुए तो phenotypically they look like a female is what you need to remember, but genotypically they are 46XY male is what you need to basically remember. So male pseudohermaphrodites are all autosomally recessive. Absent Leydig cells or an abnormal LH receptor is the underlying cause for the male pseudohermaphrodite is what I want to underscore. So what is the most common enzyme leading to the development of the childhood hypertension? Hypertension होना बोले तो steroid activity, aldosterone activity should be high. I mean mineralocorticoid activity should be high. Both 17 and 11 दोनों में mineralocorticoid activity will be high, but 11 is more common, responsible for the childhood hypertension prevalence wise is what you need to remember. Now doc, 11 beta is a hypertensive variant of SIADH and second most common cause of the SIADH overall after 21, right? But 21 alpha hydroxylase is a salt losing type where hypotension will be there, whereas 11 beta is hypertensive and most common hypertensive SIADH is 11 beta. That is what you can easily remember. So once more, 11 beta, why it is hypertension? Because 11 beta may 11 deoxycortisol cannot become the cortisol. I mean corticosterone cannot become corticosterone. So this 11 beta deoxycorticosterone level is very high and that lead to development of hypertension, and at the same time there is virilization is what you need to remember. So what is the most common adrenogenital syndrome that you classically see? It is the 21 alpha hydroxylase which is the most common one. Now what is the most common cause for the female pseudohermaphroditism? That is genotypically they are XX, but phenotypically there is a clitoromegaly because of excess androgens that typically happens in 21 alpha hydroxylase deficiency is what you need to remember. Now what is the cause of the precocious puberty? Obviously there should be a situation where androgen levels are high. So if you look at 17, testosterone is low in 17. So there is a reason nahi ho sakta. 3 beta mein both aldosterone and testosterone dono low. Only 11 has got both aldosterone and testosterone high. So that is the reason there is a development of precocious puberty due to the excess amount of aldosterone is what you need to remember. Actually, answer should be which will lead to the precocious puberty, and the answers should be C is what you need to remember, except Nairena. So that is the correct question, way of asking the question. 2-year-old is having diarrhea, failure to thrive. That means salt losing. And sodium is 122, very low. Then most likely what are they suffering from? 2-year-old having diarrhea. So you should immediately jump and answer 21 alpha hydroxylase is a salt losing type of congenital adrenal hyperplasia. If the gonads need to become differentiated into testes, how does it happen is an important question. You require SRY gene. So what is SRY gene? It is also called sex determining region of the chromosome Y is SRY, and it is the expression of this SRY that initiates a testicular development from an undifferentiated gonad is what you need to ultimately remember. So it is present only on the Y chromosome. It upregulates SOX9, SOX9, and it is there on the short arm of the chromosome Y. Sometimes examiner will play with your life. Is it long arm or short arm? Which arm ke upar hai? That can be a question. So ultimately you will feel in exam, oh my God, I learned up to SRY. उसके बाद वो शॉर्ट आर्म में है, लॉन्ग आर्म में है, मैं पढ़ा नहीं. Oh my God, I know this topic, I know this question will be asked, I know about SRY, but I don't know about short arm. So such things happen in the entrance exam, but don't lose your heart. No one is perfect, remember. None of our classmates are perfect. All of us are at varying levels of imperfection. That's the only thing. So toppers are those guys who have least imperfection, not that they are perfect. Okay. So Swyer syndrome, where do you see this? Typically they have XY, but the short arm of the Y chromosome, the SRY gene is missing, and that lead to development of Swyer syndrome, where they look like a girl, is what you need to basically remember. So now, which hormone stimulates the gonads in the males at 8 weeks to make the gonads to secrete the testosterone is a very important question. There are many functions for the placental human chorionic gonadotropin. So, if you look at the various hormones, this graph will tomorrow straight away, it will come in your NEETPG 2019, be very sure. First trimester may what increases? HCG level significantly increase, and progesterone starts to increase, but it will be very high by the time it is third trimester, and estrogen also follows it, but progesterone increase is more than the increase of the estrogen during the first trimester. So what is meant by luteal phase insufficiency? Typically the corpus luteum produces the progesterone after the ovulation, and if the progesterone levels are not increasing after the ovulation, when the implantation occurs, that can lead to development of a failure of implantation if the progesterone levels don't shoot up. So if the recurrent abortions are because of the luteal phase deficiency, then how will obstetricians treat such people? By giving progesterone injections. They maintain the pregnancy in the post-ovulatory phase is what you need to remember. So human chorionic gonadotropin, when will it appear? After the LH search in the mid-cycle, 7 to 9 days after that it will appear. It will reach a maximum level in 8 to 10 weeks. The doubling time is 2 hours. It is episodic release, and it typically will be around 1 lakh milli international units per ml, and it declines by about 10 to 12 weeks, and it reaches a nadir by 16 weeks, which is considered to be the timetable of the HCG. Some of you are going to do MD General Medicine like Dr. Murali, but after that you will become DM Endocrinology, and maybe you will be marrying a MD Gynops girl, and she will be doing infertility practice. You will be taking care of the maintenance of pregnancy and luteal deficiencies of the patients. So that is a MS General Surgery or MD General Medicine and MD Gynops. It is a deadly combination. Of course, you need not marry for that. You can have a friend also who can be partner in your hospital, right? So, what are the biological functions of this HCG is my question to all of you. Rescue and maintenance of corpus luteum. Corpus luteum, progesterone, agar tayari nahi kar rahe hai to, still HCG will help to maintain the placenta. Now, it promotes the male sexual differentiation, and it stimulates the maternal thyroid gland. They're all the important functions of HCG which examiner is interested to know. Testis is not palpable in which situation? If the SRY gene deletion is there, testis is not palpable. So you can see the short arm of the Y chromosome of the NEETPG examiner के question bank में भी SRY gene के ऊपर questions पूछो पूछो बोल के सर्वर में रेडी रहता. आप एग्जाम को जाते ही examiner will keep throwing you the classical questions for that year. So that's the reason important thing is you should know what are the classical topics examiner is interested. So once you cover all those topics logically, reproducibly, then you are the winner. That is the only secret of entrance exam. So now doc, sex determining region SRY, it produces the testis determining factor. And by the influence of that, the testis, Leydig and Sertoli cells mature. Now Sertoli cell will produce the Mullerian inhibitory factor that will lead to the degeneration of the female Mullerian system. Then Leydig cells produce testosterone, which will make the Wolffian duct to grow well, and that is responsible for all male internal genitalia except the prostate. Testosterone becomes dihydrotestosterone that acts on the urogenital sinus and genital tubercle and convert all male external genitalia and even prostate. The growth of it is dependent on the dihydrotestosterone, and that influences the urogenital sinus and genital tubercle is what you need to fundamentally remember. Now, so that is all the story, doctor. Congenital adrenal hyperplasia. Now, let us talk about SIADH, syndrome of inappropriate ADH secretion, and diabetes insipidus, where there is a deficiency of the ADH. It can be problem in the pituitary, not producing the ADH. From which part of pituitary ADH is produced, doctor? Posterior pituitary is the one which produces the vasopressin and oxytocin. So vasopressin is also called ADH. Now, let's start the game. Which of the following is true about congenital nephrogenic diabetes insipidus? That is an important question. Now, doctor, give me the board. So, you should know very clearly as to what happens in the kidney and where does ADH act. So, in the pituitary gland, you are having a anterior pituitary, posterior pituitary, आपका TSH, ACTH, everything is coming from anterior pituitary. Whereas oxytocin, vasopressin, they are all coming from the posterior pituitary. So this vasopressin is also called ADH. Then in the kidney you have the glomerulus, the Bowman's capsule, proximal convoluted tubule, descending limb, ascending limb of loop of Henle, and finally you have the distal tubule and collecting duct. At the level of the collecting duct, you have the aquaporine channels. So ADH comes there and influences for an increased water reabsorption in the aquaporine channels in the collecting duct is what you need to fundamentally remember. Now, there are two possibilities why diabetes insipidus happen. One is, if the pituitary is not producing ADH, that is called central diabetes insipidus, or if the aquaporine channels are no more listening to ADH, even if ADH is there, aquaporine channels are no more causing water to get reabsorbed. That is called nephrogenic diabetes insipidus. Whether it is central or peripheral, what is the common denominator? ADH काम नहीं कर रहा है. अगर ADH काम नहीं करे तो water retention नहीं होगा. अगर नहीं हुए तो वाटर कहाँ जा रहे हैं? It is entering into the urine, and that is the reason what happens to the urine osmolarity in diabetes insipidus. Lot of urine. What is osmolarity? Osmolarity is electrolyte concentration in the fluid divided by the water concentration in the fluid. So अगर water ज़्यादा हो गया तो urine में osmolarity of the urine become decreased. So decreased urine osmolarity is the hallmark of diabetes insipidus. Whether the diabetes insipidus is central or whether it is peripheral, what is the common denominator? Urine osmolarity is low. Then if you lose the water in the urine, the water in the plasma become decreased. Then if the water in the plasma become decreased, osmolarity of the plasma become increased. So increased plasma osmolarity, decreased urine osmolarity is the hallmark of diabetes insipidus, is what you need to ultimately remember. So normally what makes this antidiuretic hormone get produced? Whenever you are water deprived, whenever you are dehydrated. So then what will happen? Dehydration will decrease the water in your plasma. That will increase the plasma osmolarity. And increased plasma osmolarity is a stimulus for the ADH release, and that ADH is supposed to act on the aquaporin channels. So even though the plasma osmolarity is increased, if the ADH is not produced, then that becomes the definition of diabetes insipidus. And because of the diabetes insipidus, what will happen? All water is lost further into urine, and that is the reason the diabetes insipidus by itself will lead to increase in plasma osmolarity. That is what you need to remember. So as I told you, endocrinology में खाली दो तरफ की चीजें होते हैं. First thing, if there is a deficiency, how will you prove the deficiency? You will do a stimulatory test. Stimulatory test. Stimulate करके क्या करते हैं? देखो भाई, मैं stimulate किया, फिर भी नहीं प्रोडक्शन हो रहा है. That is because there is deficiency. That's what you will prove. For example, stimulation tests are like your mock test in entrance, doctor. Right? You are already a student who is poorly prepared. You are a hypo student, hypo NEETPG syndrome. Right? आप नहीं पढ़ रहे हैं बोल के साबित करने के लिए हम क्या करते हैं? आपको स्टिमुलेटरी टेस्ट, मॉक टेस्ट कंडक्ट करते हैं. देखो भाई, मॉक टेस्ट कंडक्ट किया, इनको मार्क्स नहीं बढ़ रहा है, कम हो रहा है बोल के मैं साबित करने से क्या what become proved? That you are a hypo NEETPG syndrome. Agree? Then what is meant by hyper NEETPG syndrome? Let us say hyper NEETPG syndrome. चलो, in the medical college में आपको ना गर्लफ्रेंड है ना बॉयफ्रेंड है, नीदर सेम सेक्स फ्रेंड है, ऑपोजिट सेक्स फ्रेंड है और इंटरसेक्स फ्रेंड है, कुछ भी नहीं है. खाली आपका काम पढ़ना 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 पढ़ना. You are a hyper super duper prepared guy. Nelson pediatrics, Schwartz surgery, Harrison general medicine, सब कुछ जाके आपके दिमाग के बैठ गया, आप हाइपर NEETPG हो गया. To prove that you are a hyper NEETPG, मैं क्या करता हूं? I will try to challenge you with the most difficult questions to suppress your capability. फिर भी आप आंसर बोल रहे. So in spite of suppression, if the suppression is not happening, that means you are suffering from hyper NEETPG syndrome, is what you need to basically remember. So the same thing we will do in diabetes insipidus. अगर diabetes insipidus को है बोल के साबित करने के लिए हम क्या करना चाहिए? वेरी सिंपल. So diabetes insipidus is low ADH. So you have to do a stimulation test. That is, you create a situation that is supposed to produce the ADH. Supposed to produce the ADH. What produces the ADH? That is, you will try to create a situation where ADH is supposed to get produced and you will say, see, my इतना स्टिमुलेट करने के बाद भी ADH प्रोड्यूस नहीं हुआ, इसलिए ADH का डेफिशिएंसी है बोल के आप बोलेगा. That's how you will prove it. So what normally produces ADH? If you are dehydrated, that will lead to increased plasma osmolarity, and you will create that situation which is called water deprivation test. If you deprive somebody with water, obviously they get dehydrated and that lead to increased plasma osmolarity. So normal person में अगर आप उसको water deprive करके dehydrate करके plasma osmolarity को बढ़ाए तो क्या होता normal person में? This high plasma osmolarity stimulates ADH production. And what the normal person, if ADH is produced, what is the effect of that? It will go and reabsorb the water from the collecting duct. So if it reabsorbs the water from collecting duct, what happens in urine? The water in the urine is low. If the water in the urine is low, what will happen? Urine osmolarity is supposed to increase. So if the urine osmolarity did not increase means, what does it mean? ADH is not produced. So, if you want to prove diabetes insipidus, that ADH nahi produce ho raha hai, if you want to prove it, what will you do? You will do a water deprivation of that person, you will increase his plasma osmolarity, and you look for what is the effect of that on the urine osmolarity. अगर ADH है, अगर मर्द है, then what will happen? The ADH is supposed to reabsorb the water and increase the urine osmolarity. If the urine osmolarity is not getting increased, if you water deprive a person, that means ADH is not produced. And ADH is not produced को क्या बोलते? Diabetes insipidus is what you need to remember. Now the question is, if the ADH is not getting produced, दो कारण होता है. Either pituitary is not producing or the kidneys are not responding. So how will you prove that next? Very simple. You administer ADH to that guy. You administer the ADH vasopressin to that guy. If you administer the vasopressin, if urine osmolarity normalizes, right, if you administer ADH, what do you expect the urine osmolarity to become? Obviously, that administered ADH should act on the kidney to retain the water back into the body, and urine osmolarity is supposed to increase. So, you administer ADH and check whether urine osmolarity is increasing at least. Suppose if it increases, what does it mean? That means he has absolute deficiency of ADH, and your exogenous administration of the ADH has increased the urine osmolarity. That means he is a case of central diabetes insipidus is what you need to remember. Second situation, आप बाहर से ADH exogenous injection दिया, देने के बाद भी urine osmolarity is not increasing. That means basically water is no more reabsorbed, it is going into the urine. So urine osmolarity is remaining low in spite of giving ADH injection. That means it is a nephrogenic diabetes insipidus is what you need to ultimately remember. Shanti, Shanti, Shanti. So doctor, ये चीजें ऐसे चीजें होते हैं, एक दो बार silently you should see, take a paper, sit with your friend, and then you need to review the flow chart. That's very simple. Excellent. I am looking for that wow feeling. Abhishek Vyas bola wow. It is wow, right? I am very good, doctor. I am very good in teaching the logical things. I enjoy doing that because I used to struggle to understand them. So if I struggle, I know how you struggle, right? हाँ, चलो अभी खेलेंगे पूरा स्टोरी को. Nephrogenic diabetes insipidus, right, doctor? Nephrogenic diabetes insipidus. Any diabetes insipidus may, whether nephrogenic or whether it is central, how will be the urine osmolarity? चलो कौन बोलेगा मुझे? Who will give me the correct answer? Right. Alex said बोला कि sir one time more, बार बोलो. What I'm saying is, Alex, after this session is over, और एक बार review करो. You know, in the same video it is there. This time with less amount of apprehensions, you will review, and there is no rocket science in this, right? So, Soumi Mondal is saying there will be a low urine osmolarity. Whether it is central diabetes insipidus, nephrogenic diabetes insipidus, so ADH is not there. If it is not there, water is not retained in the collecting duct, water is lost into the urine, and hence the urine osmolarity will be low, is what you need to basically remember. It will be low osmolarity, except Alex Seth and Nagarajan. Most of you are able to catch it up, but no heart feelings, right? So, very good. So, urine will be hypoosmolar if at all it is a diabetes insipidus. So, option D is wrong. Next, nephrogenic diabetes insipidus is pituitary producing ADH? Yes. But is it acting on the kidney? No. That is the reason ADH levels will be high. So, ADH normal is wrong. Then, ADH receptors are not sensitive, which is the true statement, is what you need to remember. Sir, option C and option B are confusing. अरे B क्या है? B तो opposite है. Male का opposite, diabetes insipidus का opposite is SIADH. Inappropriate ADH secretion. Where is the confusion of considering B also? Right? B is absolutely wrong statement, right? So, doctor, nephrogenic diabetes insipidus, what are the important causes of the nephrogenic diabetes insipidus is my question to all of you. You should remember that congenital acquired causes like chronic renal disease, two important dyselectrolytemias that you need to remember. Hypokalemia, hypercalcemia are the two important electrolyte disorders. Sickle cell trait patients रहता है ना, sickle cell disorder patients. When sickle cell anemia is there, all the sickle cells will lead to a hyperviscosity, and they decrease the blood flow to the renal medulla, and that lead to the tubular dysfunction. And after all, collecting tubules are the places where ADH is acting. So that is the reason sickle cell trait also will lead to the nephrogenic diabetes insipidus. Lithium, colchicine, contrast diuretics. These are the drugs which lead to nephrogenic diabetes insipidus. And those who are having protein starvation also end in nephrogenic diabetes insipidus is what you need to remember. So, how do you treat nephrogenic diabetes insipidus? Beautiful question, right? First, kidneys don't respond to ADH. So obviously, if you happen to give vasopressin injection, क्या फायदा है? There is no फायदा. There are two ways by which you treat nephrogenic diabetes insipidus. You give a low salt diet and you give thiazides, thiazide diuretics. अभी आएगा आपको मजा. Tell me, doctor, give me the board, whiteboard. Tell me, diabetes insipidus is a diuretic condition with a polyuria, or is it a condition with oliguria? What is your answer? Is it a diuretic condition or a oliguric condition? The diabetes insipidus. My question to all of you. Please punch. Please punch your answer. Parallelly, you should talk. You keep talking. I like that. Excellent. Sai Maunika, Ranjit, Rocket Trader, everyone, Gaud also is saying diabetes insipidus is a polyuric phase or a polyuria, that is like a diuretic phase. इनको ट्रीटमेंट करने वाला ड्रग क्या है? थायजाइड. अरे भाई, थायजाइड भी डाययूरेटिक है. एक डाययूरेटिक को ले जाके डाययूरेटिक कंडीशन में ट्रीटमेंट के लिए इस्तेमाल करना, कुछ अकल है क्या ऐसे करने में? That is my question to all of you. Yes, we use thiazide, so it is a diuretic in a diuretic condition called diabetes insipidus. इसमें तमाशा क्या है? What is that magical secret of giving thiazide? So it is a diuretic in a diuretic condition called diabetes insipidus. I am going to now make you champions. आप immediately after this session is over, reading room को जाके किसी को पूछो, भाई नेफ्रोजेनिक डायबिटीज इंसिपिडस में क्या इस्तेमाल करेगा? आपका दोस्त बोलेगा वासोप्रेसिन इंजेक्शन देता हूं. छोड़ो उसको, ही इज अ वेस्ट फेलो. मतलब एटलीस्ट ही इज नॉट वेरी श्योर व्हाट यू विल that nephrogenic diabetes insipidus में vasopressin काम नहीं करेगा. उनको there's no point in asking. You ask another friend, that super duper hyper NEETPG guy, hyper NEETPG syndrome guy. So वो बोलेगा कि reflexly thiazide I will give. You ask diabetes insipidus क्या होता है? Diuretic state. Thiazide क्या होता है? Diuretic state. Why do you give diuretic in a diuretic state is the question. Very simple. Fundamentally, you have a glomerulus, Bowman's capsule, proximal convoluted tubule, descending, ascending limb of loop of Henle, and finally became collecting duct. Where are the aquaporin channels, doctor? They are there on the collecting duct is what you need to remember. Now, the problem in diabetes insipidus is ADH acts on the collecting duct to cause water reabsorption. If this is not either produced in pituitary or not acting on the receptors, water reabsorption doesn't occur, so you are losing the water. That is the whole problem in diabetes insipidus, even in nephrogenic diabetes insipidus. So, what happens normally? How does the water reabsorption occur? 80% of the water, doctor, is reabsorbed in the proximal convoluted tubule only. Proximal convoluted tubule is called the workhorse of the nephron. Bicarbonate reabsorption, electrolyte reabsorption, water reabsorption, all reabsorptions basically occur in the proximal convoluted tubule. Now, this proximal convoluted tubule 80% suck करने के बाद remaining 20% को यहाँ भी जाएगा. But by chance, if the ADH is there, it will make even this 20% not lost into the urine, and it will try to retain. So, ADH का पूरा contribution देश की प्रगति के लिए खाली 20% है. 80% प्रगति देश का कहाँ हो रहा है? It is happening in the proximal convoluted tubule. But this proximal convoluted tubule has a special property. क्या है? अगर proximal convoluted tubule knows, if it happens to know that the guy is severely dehydrated, वो 80% नहीं 100% यही reabsorb कर लेगा. It won't leave a chance for the collecting duct. मगर somebody should go to the proximal convoluted tubule and tell, hey, proximal convoluted tubule, आपके अध्यक्ष महोदय severely dehydrate हो गया बोल के proximal convoluted tubule को बोलना है. So कैसे पता चलेगा proximal convoluted tubule को that the person is dehydrated? If the person is dehydrated, there is a decreased glomerular renal blood flow, decreased GFR. The moment there is a decreased GFR and the amount of filtrate in the proximal tubule has decreased, that makes the proximal convoluted tubule to reabsorb instead of 80%, entire 100% of the water in the proximal convoluted tubule. One more way proximal convoluted tubule will wake up from the sleep. What is the second way? Whenever the electrolytes are low in the proximal convoluted tubule, immediately it will identify, oh my god, they are low, and it will increase the water reabsorption. So by giving thiazide, what are you doing, doctor? By giving thiazide, you are initially causing loss of water and electrolytes into the urine, and because of that you are decreasing the GFR and you are waking up the proximal convoluted tubule and make it to reabsorb the entire 100% water. And though there is no ADH, though the aquaporin channels are not working, फर्क नहीं पड़ेगा क्योंकि पूरा 100% reabsorption proximal tubule में हो गया. So that is how you will use the thiazides is what you need to basically remember. So doctor, please remember, basically proximal convoluted tubule is also like you guys NEETPG aspirants. NEETPG aspirants है. मगर NEETPG aspirants think collecting duct is like what? Last moment before exam, right? You will think that, hey, last moment before exam, I will quickly reabsorb as many topics as possible. And you will be very lethargic during preparation. What is the role of Dr. Murali Bharadwaj evening chai pe charcha classes? We are like thiazide diuretic. हम आके आपको रोज बताएंगे कि you are so severely dehydrated, the topics don't leave it to the last moment. They are very high yielding in nature. So the proximal tubule every day will try to reabsorb everything, and it doesn't give a chance for the distal tubule or the last moment deficiencies. That is the function of thiazide diuretics in the management of diabetes insipidus is what you need to remember. So Ranjit is saying, wow, wow, Jabardast, beautiful, beautiful. So doctor, thiazide, chloropropamide, they are the ones which can be used in nephrogenic diabetes insipidus. Now comes the syndrome of inappropriate ADH secretion. What is it characterized by? This last time we discussed in our PGI AIMS question bank discussion. What is meant by inappropriate ADH secretion? What is meant by inappropriate anger? Your boyfriend is studying in the reading room. Just jaake you gave a sweet smile and then rubbed a bit of his hair because he's still having a lot of hair and said, hey, what's going on? Suddenly he had an anger burst on you. What is the reason for his anger burst? You are not responsible. You are very prettily looking and you went with a wonderful perfume. You are sitting on his side. But that fellow is having a anal fissure about that stress about the forthcoming NEETPG. So inappropriately he burst anger on you. That is inappropriate. Normally ADH is supposed to get produced if you are dehydrated. If though you are not dehydrated, you are euvolemic, you don't have cardiac failure, renal failure, hepatic failure, nothing is there. Though you are euvolemic, if ADH is unnecessarily getting produced, that becomes the SIADH is what you need to fundamentally remember. So what do you get in SIADH? All that inappropriate ADH, what will it do? What will it do to the body? So let's talk three important things about SIADH. Give me the what. So doctor, whenever there is SIADH, what will happen? So the renal tubule, the descending limb, and ADH collecting duct. When excess ADH is there, there's a lot of water reabsorption. All this water is entering into plasma, and that is increasing the plasma volume. And that increased plasma volume will make the atrium to get excessively stretched. The stretching of atrium will release atrial natriuretic polypeptide, and atrial natriuretic polypeptide acts on the kidney and lead to development of natriuresis. So that will lead to lot of sodium getting lost into the urine. So one of the important definition of SIADH क्या होता है? Water is excessively reabsorbed, so plasma osmolarity become low and urine osmolarity become high and urinary sodium become high. In a euvolemic person, without thyroid, without liver, without renal, without adrenal, without congestive heart failure, cardiac failure, presence of this combination of features defines the SIADH is what you need to basically remember. So doc, hyponatremia, because you have a plasma volume increased. So because of that, the sodium concentration in the plasma become low. And also sodium is lost into urine. So urinary sodium more than 20 milliequivalent per liter is considered to be the definition. Schwartz diagnostic criteria for SIADH. This table, mark it in the UMedico app and ask it to give you the notifications. Most likely tonight onwards, UMedico notifications, reminders, everything start working. So don't worry. Yeah. So serum osmolarity less than 275. Clinically euvolemia. Urine osmolarity more than 100 milliosmoles. Urinary sodium more than 40. Normal thyroid, normal adrenal, normal renal, and no acid-base disorders or no hypokalemia. Additionally, they will have a low serum uric acid levels because of the plasma volume expansion. Blood urea nitrogen concentration become decreased less than 10, and fractional excretion of sodium will be more than 1%, and in spite of giving normal saline, their hyponatremia doesn't improve. So that is and their hyponatremia only improves if you do fluid restriction. Then what will happen if the fluid restriction obviously the whole problem in SIADH is plasma volume expansion. So you need to once more bring them back to a normal plasma volume, means you need to restrict the fluid intake. That is the only way by which SIADH can be treated, is what you need to understand. So this is one important frequently asked question SIADH. SIADH में hyponatremia रहता, मगर उसको ट्रीट करने के लिए 0.9% saline देता क्या? नहीं देती. So how do you manage SIADH? By restricting the fluid intake, you will be managing the SIADH because it is a high water retention into the plasma and plasma volume expanded state, and that need to be stopped by restricting the fluid intake is considered to be the treatment of choice. Very good. The rocket trader is asking, sir, revise all topics. No, tomorrow you are going to have excellent teacher, a cardiothoracic surgeon, Dr. Gautam Chakravarti. Once upon a time our student, and his MS ke baad once more he topped the entrance exam. He will make learning just a cakewalk in surgery. Take it as my word. So he said that, don't worry sir, though I am a cardiothoracic surgeon, I love to come and teach the students. So evening I will be on time, and then Tuesday, Wednesday, Thursday, 3 days he will be teaching the surgery. There are about 300 questions in the last 5-6 years of NEETPG, topic-wise organized in surgery. He will do the revision in the next 3 days. Okay, right. Now, doctor, patient is given vasopressin, but it is not increasing the osmolarity of the urine. What does it basically indicate? Obviously, it indicates the renal hyposensitivity towards ADH is what you need to basically remember. Now, this all of you know very well. If you give vasopressin, what do you look for in the urine? If the urine osmolarity and the specific gravity, both of them decrease, that means to say it is a central diabetes insipidus. But in spite of giving vasopressin, if the urine osmolarity and specific gravity does not change, it is called nephrogenic diabetes is what you need to remember. Jaswinder Kaur is saying, I know some of the best Punjabi friends that I have, women surgeons, a lot of women surgeons from Punjab. So, I wish Jaswinder Kaur also becomes MS or MD, gynops, is all our dream, right? Now, this is one table, doctor. This is the table which examiner is going to give you in the tomorrow's exam. Sandeep is asking, sir, explain urine osmolarity, plasma osmolarity. दोनों osmolarity है. Osmolarity is dependent on what? Numerator में electrolytes, denominator में water. अगर यूरिन में ज्यादा वाटर है तो यूरिन ऑस्मोलैरिटी कम होगा, प्लाज्मा में ज्यादा वाटर है तो प्लाज्मा ऑस्मोलैरिटी कम होगा. If the person is dehydrated, his plasma water is low, that's the reason plasma osmolarity is high. If the patient is typically losing a lot of water, diuretic, then the urine osmolarity क्या हो जाता? Denominator, water is high, so that is the reason urine osmolarity become low. If you are producing voluminous urine is what you need to remember. Oh, very good. Neta Mahesh gives a very good Telugu compliment. That's good. Now, doctor, you have plasma osmolarity, you have urine osmolarity. Nephrogenic diabetes hai. If you deprive the water, what do you expect in these people? Whenever you, in a normal person, if you deprive the water, right, you are dehydrated. So dehydration lead to ADH formation. ADH lead to water retention into the plasma and low water in the urine. And what is supposed to happen to the urine osmolarity? Urine osmolarity is supposed to increase. But with the water deprivation, if nephrogenic diabetes insipidus or central diabetes insipidus, there is no rise of the urine osmolarity. Urine osmolarity. That is indication of diabetes insipidus. But if you give vasopressin, if the urine osmolarity is increasing, that means it is a central diabetes insipidus. In spite of giving the vasopressin, if the urine osmolarity remains to be low, that is nephrogenic diabetes insipidus. That is what you have to basically remember. Now, where do you see inappropriate ADH secretion? There is a big list which you should remember. Small cell cancer, mesothelioma, stomach cancer, pancreas cancer, bladder cancer, prostate cancer, etc. I am not going to read all these things. But one thing please don't forget, that anti-epileptics like carbamazepine, antipsychotics, what do they lead to? Syndrome of inappropriate ADH secretion is what you have to remember. Now, what is true about nephrogenic diabetes insipidus? Renal tubule unresponsive to ADH, all of you know very well. So this is one important flow chart, doctor, what we have discussed till now. It's very easy. You do a 24-hour water deprivation. After the deprivation of the water, look at the urine osmolarity. If the urine osmolarity is more than 40, that is, if you deprive the person, if the urine osmolarity is high, means there is low water in the urine, that means ADH is working, right? So then don't worry, don't worry. Suppose if urine osmolarity is not increased in spite of water deprivation of the person, that means he is having diabetes insipidus. So just run through this flow chart and you can be able to answer totally, but please bookmark this. That's good. We'll finish few more questions and go ahead with the quiz shortly. Now, how do you treat nephrogenic diabetes insipidus? Jump and answer the question, doctor. Neurogenic, that is central diabetes insipidus, we will give desmopressin. So this is a typical desmopressin acetate injection which you need to ultimately remember. Now, in the nephrogenic diabetes insipidus, what do you have? You have a high vasopressin, you have a poor or no response to desmopressin, and there is a high plasma osmolality, right? Because all water is lost into urine, water is low, so plasma osmolality will be high. So that is what you have in diabetes insipidus. You are given exogenous vasopressin, but it is not increasing osmolality of the urine. What does it mean? That means it is a nephrogenic diabetes insipidus. You can see how frequently examiners keep playing with you with this. Then, what is the main part of the treatment of the nephrogenic diabetes insipidus? As we already discussed, thiazide, amiloride, diuretics and salt restriction. Whereas SIADH treatment, fluid restriction. Now I think you all know, you know very well how to remember it. ADH नहीं है तो salt restrict करो. ADH ज़्यादा है तो fluid restrict करो. Simple. Now, polyuria with a low and a fixed specific gravity, what does it indicate? Isostenuria. Isostenuria is a sign of the chronic kidney disease which happens in chronic glomerulonephritis. So, what conditions decrease the specific gravity of urine? Polydipsia, diabetes insipidus, diuretics, early stage CKD. What increase specific gravity? Diabetes mellitus, dehydration, proteinuria, glycosuria, they increase the specific gravity. You call hypostenuria if it is less than 1.007 and hyperstenuria if it is high and isostenuria if it is fixed, that means tubules are no more working. Whether you are dehydrated or you are edematous or you are overhydrated, जो भी हो एक ही standard वाला specific gravity high बोले तो your tubules are not working, which typically is seen in chronic kidney disease is what you need to remember. So the remaining questions in this topic we will discuss in the next session, doctor. So, you're all ready for the quiz? Please unfreeze your fingers. Yeah, I'm not going to delete this video. आज तो बहुत claps are coming from you. I'm definitely not going to delete this video. Let it be a good advertising video for all the other students who come after this session is over. Yes. Now, doctor, the time has come where you have to tell me the answers and I have to listen your answers. Are you ready for the game? Yes. Abhishek is asking, sir, you are in a good mood today. Yes, definitely. Very good mood. क्योंकि लॉजिकल टॉपिक्स के चर्चा होता है ना, चाय पे चर्चा, वो तो मसाला चाय पे चर्चा होता है. And that too with wonderful students across the country, 213 being online. I am बहुत खुश हो गया, right? So, yes, most of you are saying C versus D. Prateep Kumar is saying C. Aparna thinks D. Why you are all attracted to D, doctor? So, GFR is dependent on the height, body surface area, best estimate by creatinine clearance, and there is a decrease after 70 years. They are all important things. Membranous glomerulopathy. Where do you see? Question number 272. Shoot your answers quickly, doc. Membranous glomerulopathy. Where do you see? Yes. I can be able to see, yes. I can see Ravi Prakash, one more Ravi in the group. Kabir Nanda, you're all differing between D and A. Most of you are attracted to A. No, doctor, this we discussed so many times, right? Malignancy, always. Membranous nephropathy, अगर elderly person membranous nephropathy के साथ आए तो look for the internal malignancy, which is lymphoreticular malignancy, like a lymphoma. You should do a thorough checking. So, SIADH is absolutely right about malignancy. Positive dipstick for RBC with a red color in the urine and a clear supernatant after centrifugation. What is it because of? Question number 273. Narendra Tengli. I think first time Narendra is attending today's evening. So please remember, doctor, every day evening, tell all your friends, 365 days of the year, rain or sun, storm or norm, we are there to have this 2.5 hours session and get ourselves spiced up for the preparation. So please tell all your friends to forget about costly face-to-face classes here and there and come to the free classes on the YouTube and take a subscription on the UMedico and play with your friends, and that is how you should prepare. So, Sai Maunika, everyone is saying hematuria, but doctor, red color urine is the important clue of hemoglobinuria, which is myoglobinuria, which is seen in the case of the rhabdomyolysis. Where do you see RBC cast? Hyaline cast, RBC cast, granular cast. Granular cast का मतलब होता है angry urinary sediment, it is called as. If you are having glomerulonephritis, very active glomerulonephritis, you get granular cast. So SLE patients, etc., whenever you are doing urinary examination, SLE patient with kidney involvement, अगर granular cast दिखाए तो that means your immunosuppression is not yet effective. So इसलिए यूरिन को क्या बोलते हैं डॉक्टर? आप बोलते हैं क्या पेशाब का रिपोर्ट है ना? Okay, you'll say no. Urine examination is called poor man's renal biopsy. जो आम आदमी renal biopsy के लिए पैसे नहीं है, यूरिन देख के बोलना पड़ेगा आपको डायग्नोसिस क्या है and start the treatment. इसलिए urine sample is called poor man's renal biopsy is what you need to remember. So doctor, acute glomerulonephritis में RBC cast होगा, oliguric renal failure, all these are the causes. Where do you find a diuretic kind of a renal failure? Question number 275. 275. Yadvinder Singh, wonderful to see you from Ludhiana. Excellent. So 275. After 50 years also you come and tell me, I will remember your names and from which location you are from. Right? So Sareem Hussain is one more new student answering it as A. Sudha Shukla thinks diabetic nephropathy is except. No, doctor. Multiple myeloma, Fanconi, diabetic nephropathy, everything can lead to oliguric failure, not the aminoglycosides. That's very, very important to remember. Now, hemodialysis kar rahe aap. Which organism infection is a notorious infection that you are really worried about and you want to attack it? Ravi thinks gram negative, Ritu thinks 276. Yes. Shabazz thinks gram positive. Very good. Dasari Sushmita said anaerobes. Gram positive, doctor. Commandant Jindabad. Excellent, excellent. So, in the infection of hemodialysis commonly comes from the catheters, everything you have the Staphylococcus epidermidis, etc., which are all gram positive. Gross hematuria, किसमें रहता है? The patient himself will come and say, hey doctor, my urine is very red in color. I don't need microscope. Which patient will tell? Should your answer, doctor? Question number 277. Divya is thinking nephritic syndrome, smoky urine, but gross hematuria. Excellent. Dasari Sushmita Jindabad. IgA nephropathy is called benign recurrent hematuria. And 1-2 days के पहले sore throat हुआ डॉक्टर, upper respiratory infection हुआ, आज red urine आ रहा है डॉक्टर, help me. If he says what is that called? Synpharyngitic hematuria is the classical feature of the IgA nephropathy is what you have to ultimately remember. Xanthogranulomatous infection, where do you see? Don't worry, Roger, you will get more answers correct, right? Yes. 278, xanthogranulomatous infection. Yes. 278. Ritik is saying Proteus mirabilis. Excellent, doctor. All of the above, in fact. Nephrolithiasis, urinary obstruction, and Proteus mirabilis. Hypokalemia, where do you classically see? Hypokalemia, 279, is a very important question. This you have to answer confidently. In fact, there are two answers for this. Two answers for this. 279. Of course, there is no 3. 3 to nahi hai. 1 and 2 are hypokalemic, and type 4 is hyperkalemic type of renal tubular acidosis. अगर ये आंसर रॉन्ग करे तो रीनल ट्यूबुलर एसिडोसिस यू मेडिको ऐप के वीडियो लाइब्रेरी में जाके काइंडली रिवाइज टुनाइट. प्रॉमिस मी दैट यू विल डू दैट. डीएनबी वीडियो लाइब्रेरी, हाई टॉपिक वीडियो लाइब्रेरी, एम्स वीडियो लाइब्रेरी, सारे जगह हम हाई टॉपिक लिस्ट में ये डिस्कस किया. There is also beautiful PowerPoint slides of the discussion. But you should not do a mistake about renal tubular acidosis. Okay, doc? That's your promise. Acute renal failure, what does it result in? Question number 280. 280. Acute renal failure may versus chronic renal failure, you should be very sure. Yes. Akhil is saying C. Monica Sharma is saying hyperkalemic alkalosis. Aparna thinks it is hyperkalemic acidosis. Absolutely. Aparna Jindabad. Acidosis तो होता है, renal failure में hyperkalemia होता है. That is the reason we do dialysis, right? Now, what causes acute renal failure? What is except out of all this? 281. Shoot your answer, doctor. Yes. So all these daily quizzes are archived in mock test folder in the UMedico app. So please, you can review the previous quizzes, everything on that. Yes. Question number 281. I can see most of you saying D versus A. D is right. So pyelonephritis, snake bite, rhabdomyolysis, all acute renal failure. Analgesic nephropathy is basically a papillary necrosis, tubular dysfunction, not presenting as a acute renal failure. Now, steroid stones, what is true statement about it? 282. Yes. Should your answer, doctor? So, 210 online students today evening. I can see 5 to 6 of you are new students. So, please don't forget to give a call to our helpline, and they will give you the UMedico subscription, and we will be very grateful if you also pay for the subscription and join, and that will help us to support this mission. So, our everyday evening free classes will be free forever, all 365 days. Our UMedico subscription is a paid subscription, mock tests, notes, video library, everything you get on that. And all these sessions are all archived on the UMedico app. So please take a chance to WhatsApp our helpline and buy the subscription. Yes. So I can see A versus D in this. Steroid, alkaline urine. There is no second thought about it, right? Now, these are all seen in nephrotic syndrome. What is accepted about it? In nephrotic syndrome, people will have a hypercoagulable tendency. Question number 283. Should your answer, doctor? Yes. Praveen Gaud, Sai Maunika, Nagarajan, everyone is betting on C. That's right. Hypertension होता है nephritic picture में. Red cell casts are common in which situation? 284. Yes. 284. Yes. Yes. Abhishek is asking, are you teaching every day, sir? Definitely, sir. All 365 days, हम तो completely jobless, unemployed MD general medicine है. हमको teaching के बिना कुछ और नहीं आता है. So, we will be there with you every day, right? So, don't worry. C versus B. Nephritic syndrome, red cell cast. Interstitial nephritis, where do you see? 285, right? Yes. 285. Question number 285. संदीप पूछ रहा है कि सर नेक्स्ट 19 दिन लेक्चर किया तो कितना क्वेश्चंस प्रोबेबिलिटी आएगा, कितना आएगा, कितना जाएगा, उसके बारे में कभी भी परवाह मत करो. अपना कर्मा, follow your karma. So that is what you should follow. Don't worry about results, right? So then only you will be little lightweighted and prepare. जो भी मिला है टाइम, इसका इस्तेमाल सही तरफ करो. That is important, right? So I can see NSIDH as an answer. Hemorrhagic stroke. What can be given immediately in hemorrhagic stroke is a very important question. 286. Should you answer, doctor? Yes. Yes, 286B. Alek is saying, sir, आप पढ़ाते हैं इसलिए तो मेडिसिन समझ रहा है. हम भी बोल रहे हैं, अलेक जी, आपको पढ़ाने की वजह से हमको भी मेडिसिन समझ में आया. The same feeling over here also, right? So the answer is, it is the hypertonic fluids that can be given in case of the hemorrhagic stroke, not transfusion colloids or packed RBC. Women working in hot environment, drinking lot of water without salts, what will happen? सब कुछ heat है, मगर heat cramp, heat hyperpyrexia, heat stroke, इन चीजों में बहुत फर्क है. So we will discuss this in a separate topic in forensic medicine. So 287, what is your answer? Monica calls it cramps. Cramps, very good. Hypocalcemia, it will not lead to what? 288, hypocalcemia. 288, will it lead to QT prolongation or QT shortening? Is a very important question. 288. SIADH is betting on C. Rocket Trader is saying osteoporosis. Beautiful. Rocket Trader Jindabad. Sab log lost the game. Clean bowl. So porosis होता है मैट्रिक्स के प्रॉब्लम. ऑस्टियोमेलेसिया होता है हाइपोकैल्सीमिया, लो विटामिन डी एक्सेट्रा एक्सेट्रा. अरे इतने बार हम डिस्कस किए डॉक्टर साहब, आप रॉन्ग नहीं करना, राइट? So after road accident, patient presented BP 90/60, heart rate is only 56 beats per minute. This is a very important clue for you to answer. Come on, shoot your answer. 289. Excellent. Neurogenic agar hai to shock. You have a low heart rate in spite of hypotension is what you need to remember. Which stays least in plasma? Plasma में किसको G नहीं दे, which has got a short half-life, is a very important question. किस substance को जीने नहीं देते? Enzymes. So Ravi is thinking renin, right? Shortest half-life. Monica betting on norepinephrine. Praveen, Abhishek, everyone betting on norepinephrine. Easy, right? Norepinephrine, obviously we don't want it too much, too long. Otherwise our BP will shoot zoom like a rocket. Now what is the incubation period of hepatitis B? If you answer this wrong, doctor, you are getting ready for the DNB June, not for NEETPG 2019. फटाफट बोलो, incubation period of hepatitis B, 291. Yes, 291. Avinash Gaur, Saumi Mandal and Aparna Nori, they're all thinking 45 to 180. And Monica, don't break my heart. So 45 to 180, you should remember. Now doctor, HIV infection, ART is not started among these, which becomes the initial presentation of the HIV. So once more, depending upon what is the lymphocyte count, different infections happen in the HIV. So you should be sure which infection at what level of the lymphocyte count, CD4 count. So Ilias betting on C, and I can see Deb MBBS is saying A. Absolutely, Ilias is right. Bacterial pneumonias से शुरू होता है HIV का story. What are the most important parameters if you want to monitor dengue hemorrhagic fever? Is my question to all of you. Yes, Krina Shah is our new classmate. So Dr. Krina, you are from which location in the India? Are you from Gujarat, Krina Shah? So obviously Amit Shah, Narendra Modi, Kinasha should be from Gujarat, right? So 293. Gujarat students, very studious students I ever had. बहुत मेहनत करके पढ़ाई करके yeah. Krina, you are from which part of the country? Yes. Exactly. Which part of Gujarat? So, Ritvik Karmuri is proposing hematocrit. Absolutely right. Question number 294. That's right. Alex said also. Causative agent for hand, foot, mouth disease. Guys, you should all bring your classmates, not only attending yourself. I want to see this number 227, 230 is boring for me. I want you to promote this and get me 5,000 students attending every day evening for the evening class. Right? Right. So, I can see Coxsackie virus, absolutely. Actinomycosis में treatment of choice. अगर ये wrong करे, आप यू मेडिको माइक्रोबायोलॉजी फिर जाके गर्मा गर्म पढ़ना पड़ता. Should your answer, doctor? 295. Ravi, Akhil, Roger, Aparna, all of you are calling it as Rituraj. Don't tell me ceftriaxone. People also clean bowl. Penicillin. Penicillin. Nagarajan, don't be attracted to unknown devil is more dangerous than a known devil. Please remember in entrance exam, right? Best treatment for swine flu. What is your answer? The last 5 questions. Fatapat answer karo, doctor. Swine flu mein, what is the best treatment? 296. Akhil is saying yay. That's good. Most of you are saying yay. Oseltamivir, absolutely. Tummy flu. Rickettsia is treated in all ages. What is the common drug of choice for everything? So, doctor, I am posting CuroChat, CUROCHAT, YouTube channel. After this class is over, immediately go and click on the notifications, the subscription button of the CuroChat in the YouTube CuroChat channel. And this is for all patient education series that we are starting. Thank you. A good number of you yesterday have joined the CuroChat subscription. But even remaining people also, tell your friends, family, patients, everyone, tell them that there are a lot of patient education videos on the CuroChat YouTube channel. So please subscribe to it and make others to subscribe. And if you have not yet subscribed to this online MBBS channel, please press on the subscription button and the bell sign in order to get the reminders. So it is a doxycycline. Empirical antibiotic treatment in community acquired pneumonia in a previously healthy individual. Very good. So thank you for the compliment, Commandant. So yes, Sandeep is asking, sir, snake bite poisoning ke baare mein. Definitely. I have a lot of primary health center doctors day in and day out treating. I want next time he holds the snake and tells how he is treating and how the antivenom is injected and how the patient is recovering. The entire video we will shoot and then put it as a patient education mark. Yes. Dev MBBS is saying how to subscribe. Type CuroChat in the YouTube search, and once you type, you get the channel, YouTube channel. There subscribe button. Usko maro. Right? So, azithromycin is considered to be the treatment of choice. Janvi Bhatt is absolutely right. Mad cow disease is because of what? Should you answer, doctor? 299. Saumi Mandal, I still remember MD resident I was. सीरियसली इमरजेंसी में लॉट ऑफ क्राउड इज देयर लिख रहे, मेरे सामने एक विलेजर कोबरा को पकड़ के, डेड कोबरा को पकड़ के खड़ा है। So I just what is the problem of the patient बोल के हेड राइज किया, मेरे सामने कोबरा was there, I mean dead cobra. So villagers are very interesting, right? So Vamshi is our new friend. Protein misfolding, absolutely. Sputum smear is diagnostic if how much you find in case of pneumonia is my question to all of you. The last question for the today evening. Should you answer, doctor? Yes. So question number 300. That's right. Right. So Ritvik is proposing more than 25 neutrophils. Ritvik Karumuri. Everyone is betting on A. SIADH thinks it is D. It is D. No. More than 25 neutrophils and less than 10 squamous epithelial cells. That is what you need to remember. So if you find some interesting cases, doctor, please take a consent of the patient and take a word about the sign symptom of the patient, and you also give a bit of intro about that particular case. What are the symptoms, what are the signs, what were the investigations, and how did you treat? And send me that 10-15 minutes of video by you. You can record on the smartphone, but you take a consent of the patient and do it on smartphone and send us. We will upload it into CuroChat, and that becomes a patient knowledge video. If each of you send me one case every day, you know, we can create one of the largest teaching both patients and medical students को teach करने वाला YouTube channel on CuroChat. So all of you hope will help me in this mission. You have our helpline number. If you teach a case, if you classically record a interesting story of the patient in his own words, how the SLE started, how many days she's having, and what are the medicines she is taking, and because of that, what are the side effects she is passing through. If you can send me, each of you, one short video, 10-minute video, we will upload it into the Umedico, into the both Umedico app and also CuroChat, and that is going to help a lot of patients to learn from the other patients how the things are happening. So thank you very much to everybody, and once more, see you all tomorrow evening at 5 p.m. and Dr. Gautam is going to help you a lot. Thank you very much and read well.